Hi, everyone, and welcome. Thank you for joining our PRISM Summer Scholars webinar. My name is Allison Stepanok. I'm an SMS mom and a member of the PRISM's Board of Directors, and I'll be your moderator this evening. The PRISM Summer Scholars Program is an initiative that supports emerging researchers as they explore focused projects related to Smith-Magenis syndrome under the guidance of experienced mentors. It's designated to foster the next generation of experts while advancing meaningful research that benefits the SMS community. We're excited to share two Summer Scholars projects during tonight's presentation. Nikki Perino from the University of Florida, who will be speaking on understanding feeding concerns in individuals with SMS, and Xingyi Chen from Baylor College of Medicine, who will share research on the remote assessment of activity in sleep in SMS. A quick note before we begin, this session is being recorded and you'll be able to access it later on prisms.org under the Education tab. If you have any questions during the presentation, please drop them in the Q&A box at the bottom of your screen, and we'll leave time at the end of each individual presentation to address as many as we can. So let's get started. I'm excited to introduce our first speaker this evening, Nikki Perino. Nikki is a doctoral student at the University of Florida studying psychology with a focus on behavior analysis. She also works as a registered behavior technician in a pediatric feeding disorders program where she provides behavior-based feeding interventions. Tonight, she'll be sharing her work on feeding concerns in individuals with Smith-Magenis syndrome. Nikki, thank you so much for being here with us this evening. Feeding concerns are something that many families navigate, so we're especially grateful for your focus in this area. And we're looking forward to hearing all of your insights. And I'll turn it over to you now.
Hi, everybody. Does this look good?
Perfect.
Awesome. Um, I am Nikki Perino. First, I do want to thank the PRISMS organization for the opportunity to come and discuss our ongoing literature review. I'm very excited to share our findings with you all today. So this presentation is going to be an overview of a literature review that we conducted last summer that looked at the representation of Smith-Magenis syndrome within the behavior analytic feeding literature. So, starting with some background, eating and drinking occur multiple times a day, across settings, and with different individuals. Simply meaning kids eat breakfast, lunch, dinner, and snacks in different environments like home, school, restaurants, and with different individuals like caregivers, teachers, and friends. Additionally, feeding involves complex learned behaviors that are significantly impact an individual's growth and nutrition. So, when a child is not eating and drinking well, they might be experiencing growth delays and they might not be obtaining adequate nutrition, and this could cause ample amounts of caregiver stress and anxiety. Severe feeding difficulties affect up to 35% of typically developing children and up to 90% of children with developmental disabilities. Most of these children do meet the diagnostic criteria for pediatric feeding disorder or avoidant restricted food intake disorder, the two known feeding diagnoses. Feeding difficulties are heterogeneous, meaning that they may not look the same across all children. In addition, they can be multiply controlled, meaning that there might be more than one reason why the feeding difficulties are occurring. There are four domains of dysfunction within the diagnosis of pediatric feeding disorder. The first one is medical. So a child might be having medical symptoms like severe chronic constipation, and that might be causing associations between eating and pain and discomfort. So if a child is feeling full due to constipation, they might associate that pain and discomfort in their stomach with eating and drinking. Nutritionally, a child might be experiencing malnutrition. There might be nutrient deficiencies due to lack of dietary diversity, or a child might rely on oral supplements like formula in order to meet their daily needs. There might be dysfunctions within the feeding skill domain, so there might need to be texture modifications, modified seating, or modified feeding strategies. There also might be slow development of oral motor skills. And then the last domain is the psychosocial domain. So there might be active or passive avoidance behavior during mealtime. So a child might be actively pushing away food, and then passively they might be clenching their teeth, such that food can't be deposited. And then there also might be a disruption of social functioning within feeding contexts. Specific to SMS, individuals could also meet these diagnostic criteria depending on the food-related behavior they present with. When we were first learning about SMS and these individuals' feeding patterns, we learned that during infancy, individuals with SMS present with low muscle tone that might contribute to oral motor deficits that may be causing early feeding difficulties. Specifically, some literature mentioned that infants present with poor sucking behavior and poor tongue control that later develops into texture aversions. Findings have also demonstrated that as these individuals age, their feeding behavior shifts to present with food-seeking behavior, which is similar to Prader-Willi syndrome, which could result in rapid weight gain and early onset obesity in later childhood. This suggests that at some point there are large shifts in contingencies and preferences surrounding mealtimes for some children with SMS. And it's important that I say some because not all individuals with SMS will have feeding difficulties. To date, behavior analytic feeding interventions are the most empirically validated, evidence-based practice for treating feeding difficulties. Using behavior analytic principles, clinicians have demonstrated increases in appropriate mealtime behavior, like acceptance and consumption, and decreases in disruptive behavior, like tantruming during mealtimes. Decades of research have demonstrated the efficacy of these interventions for children with feeding difficulties in combination with other developmental, neurological, and genetic conditions. Given what we know about feeding concerns within the SMS population, we were unsure how often individuals with SMS participated in behavior analytic feeding interventions. Thus, the goal of our review this summer was to comb through the literature and determine representation of individuals with SMS in published behavioral feeding studies. Across APA PsycNet, EBSCOhost, and Medline, we searched terms including Smith-Magenis syndrome, pediatric feeding disorder, avoidant restricted food intake disorder, inappropriate mealtime behavior, which is another way of saying disruptive mealtime behavior, food selectivity, and food refusal. To be included, the study needed to include participants with SMS, a behavior analytic intervention for treating feeding relevant behavior, and be published in a peer-reviewed English language journal. Studies were excluded if they were animal studies, examined treatment of eating disorders, or included behavior analytic interventions for non-feeding related problem behavior. Upon completion of our search, most databases provided 0 reports as exemplified here. Medline was the only database that came up with 1 report. However, it did not include a behavioral intervention that focused on feeding-related behavior, and as such, it was excluded. This left us with no studies to include in our review. Knowing that SMS has not been represented within the behavioral feeding literature, and given what we know about Smith-Magenis syndrome and their unique feeding trajectories, today I wanted to show some examples of data that are collected during a behavioral feeding admission to demonstrate how these interventions could be effective with individuals with SMS given their unique feeding behavior. Behavior analytic feeding interventions include procedures to increase oral consumption of a wide variety of solids and liquids and decrease disruptive mealtime behavior, like tantruming when presented with a less preferred food. Additionally, these are not one-size-fits-all interventions, and they're tailored to address the specific needs of each individual. On the figure below, this represents an example of what behavioral interventions may look like. So on the y-axis here is the percentage of mouth clean, or also the percentage of consumption. And then on the x-axis here is sessions. So, behavior analytic interventions typically use single case experimental designs, or what are also known as within subject designs, to demonstrate the effectiveness of an intervention, which is much different than a group design where they're comparing treatment groups versus control groups. So, this particular data set is an example of a reversal design for just one participant. In this first phase here, there's no intervention, and the child is not consuming any bites. Then, when intervention is in place during this next phase, consumption rapidly increases. To demonstrate the effectiveness of the intervention, we'll also reverse back to baseline contingencies. And here we see that responding or consumption decreases to 0. And then to demonstrate the effectiveness of the intervention, once we reinstate treatment, we typically see quick recovery to high responding. Additionally, it's important to note that these sessions are typically occurring very quickly. So clinically, one session or one data point could be about 4 minutes in length. So for consumption to be increasing in about 5 sessions here early in treatment, that's occurring within approximately 20 minutes of implementing an intervention, which is very rapid responding. Now here I have some examples of specific behavior analytic feeding interventions that we've used to increase oral motor skills. For example, if a child is demonstrating poor tongue control when presented with purees, meaning that maybe they're pushing the food out of their mouth with their tongue or pocketing the food in their gums, we might present the food using a Nook brush to allow us to control where the food is placed on the tongue. This is an effective way to decrease expulsion or when a child has food dripping out of their mouth, potentially due to those oromotor skill deficits. Then once consumption is increased, we can work on reintroducing the spoon into the mealtime environment. Additionally, to strengthen oral motor skills or increase the efficiency of chewing, behavior analytic interventions have assessed the use of chew tubes or special netting to control where the food is in the child's mouth while really working on strengthening the chewing skills. Using these special tools allows for exposure and taste of food while controlling where the bite is in the child's mouth. In terms of nutrition, in early infancy, when individuals with SMS are failure to thrive or not meeting their growth and nutrition needs, dietitians may prescribe calorically dense formulas like Pediasure or Boost to supplement their calories or recommend the placement of a NG tube or a gastrostomy tube. Additionally, sometimes they might recommend including additives in the food like butter or oil, or they might allow the child to graze on food throughout the day. To date, it's unknown what causes early onset obesity in individuals with SMS, and reportedly, caregivers have found it difficult to change their child's eating habits to promote healthy eating and reduce portions. Throughout behavior analytic feeding services, clinicians closely monitor macro and micronutrients throughout an admission. As oral consumption increases, the nutrient makeup of the child's diet also changes. Looking at these figures below, each figure represents a different macro or micronutrient. So here we have the percentage of caloric needs met, the percentage of fiber needs met, and the percentage of protein needs met. And each one is all across different time points. So the initial evaluation, week 1 of the admission, 4, and 8. On the far left figure, there's a clear, steady increase in oral calories from the child's initial evaluation to week 8 of their admission. In the middle figure, the child is exceeding their fiber needs, which is great because most people are not meeting their fiber needs through dietary intake, and fiber also promotes healthy bowel movements. Finally, the figure on the right demonstrates, again, exceeding protein needs, but this was a positive change for this particular child because they were beginning to lose weight and their pediatrician needed them to gain weight a little quicker. Lastly, for many individuals with SMS, constipation is a large concern. Behavior analytic feeding interventions seek to increase a child's variety to at least 12 new foods across the major food groups, including fruits, vegetables, starches, and proteins. As such, changes in these macro and micronutrients, like increases in oral consumption of fiber and decreased reliance on these supplemental formulas for growth, have also contributed to positive changes in bowel movement. Many children will begin an admission with hard, pebble-like, or what we would consider constipated stools. They end up tending to shift more towards normal form stools within an admission. So on this figure below here on this y-axis, we have the stool type. In our clinic, we type stools based on the Bristol Stool Form Scale, which is a 7-point rating scale. And then on the x-axis, we have the number of bowel movements across an admission. Each vertical line on this graph represents different time periods. So this first phase is the first month of the child's admission. This is the second phase of the the second month of the child's admission, and the third month of the child's admission. And then this shaded region is representative of the healthy normal form stools according to the Bristol Stool Form Scale. And what this graph depicts for us is that at the beginning of an admission, a child might have more constipated stools, having these ones and twos, where they, across the admission and towards the end, will shift to having more normal, healthy stools, which are these fours. So overall, what are the key takeaways from our research last summer? Our results showed that no individuals with SMS have been included as participants in the behavior analytic feeding literature. Now, you might be wondering why this might be. One possibility is that in early feeding studies, individuals may have had SMS but did not have a formal diagnosis, limiting representation to date. Additionally, SMS may be underrepresented due to inadequate knowledge about the unique metabolic and digestive patterns that might contribute to feeding difficulties. As such, if a provider has limited knowledge on feeding concerns specific to the SMS population, they might make recommendations that might increase the likelihood of development of early onset obesity. Moreover, there is an overall shortage of the multidisciplinary feeding clinics, in addition to healthcare professionals who understand SMS, which likely contributes to challenges with timely service navigation. Currently, there are only 9 PRISMS Research Consortium sites and 16 multidisciplinary feeding clinics nationwide. Due to the limited quantity of providers with expertise in behavioral feeding concerns and SMS, it's understandable why this gap in the literature exists. Previous studies have noted that caregivers wish they had prior knowledge about how important food would become later in life and wish contingencies had been set to promote appropriate eating behavior. As such, as early as possible, individuals with SMS should be enrolled into behavioral feeding programs to address eating concerns early on and better equip caregivers to understand and promote functional eating in the future. That is all I have. Again, I want to thank the Board of PRISMS for the opportunity last summer to really expand my knowledge on SMS and also contribute novel findings to this group to really provide a potential avenue of services to address feeding concerns for individuals with SMS.
Thank you so much, Nikki, for that really insightful presentation. We really appreciate you sharing your research with us and your expertise with us this evening. Now we'll open up for some questions for Nikki. I see we have, let's see, take a look at our questions. So the first question for you, do you find that oral motor sounds and early speech improved following these sessions and interventions?
I think it really depends. So, the representative data that I showed today was not with individuals with SMS particularly. At the time of the Summer Scholar opportunity, the UF Gainesville Research Consortium site had just opened, and they were just getting their first few participants, but they were all telehealth. And our pediatric feeding clinic requires coming in person in order to participate, which was difficult for the SMS families to commit to the 12-week mission. That's definitely something that we would want to look at as individuals are participating in services, though, because, like I mentioned, with the changes in stool patterns, we might also see changes surrounding things like the oral cavity as a benefit to behavior analytic feeding interventions.
Thank you. Yeah, that's really interesting thought. Okay, the next question is, did you track like what types of treatment were most effective?
Yeah, currently in the behavior analytic feeding inter or behavior analytic literature, the most effective intervention is known as non-removal of the utensil. So a lot of the time, what happens is when presented with a bite, a child might engage in refusal such that that bite is removed. And over time, they have this extended learning history of if I engage in this behavior, this thing that I don't like is taken away, and then I get the thing that I really like. So for non-removal of the utensil, it essentially just means we're no longer taking it away. We're just continually providing the opportunity for the child to take the bite and then pairing it with some kind of reinforcement strategy. So if you take this really tiny bite, then you get your favorite toy for 30 seconds, and then we're going to try again.
Awesome. Okay. Um, okay, then the last question I believe that I have for you is because you mentioned that it's difficult to stop SMS children's feeding habits. So dangerous to introduce these high calorie additives into their foods?
Can you repeat that one more time?
Yeah, because it's hard to stop an SMS child's feeding habits
Mhm.
going forward. Is it dangerous to introduce the high calorie additives into
So I do think that dietitians have more of the expertise in when to start prescribing some of those more calorically dense formulas or things like additives that make things higher calorie. Behaviorally, what we look at is really just decreasing that disruptive mealtime behavior and increasing the appropriate mealtime behavior such that um, we can get from where we're at with eating to what would be considered age appropriate or age typical eating. When looking at some of the current SMS literature, I noticed that with that shift from early failure to thrive to early onset obesity, there were reports that caregivers felt like they weren't able to manage some of the food seeking behaviors. And I think one of the really effective parts of behavior analytic interventions is that once those children have a wider, healthier diet variety, they might not be as food seeking towards just desserts or very specific foods. They have a wider palette to potentially choose from.
that makes sense. We did get another question come in for you, and it is, were PT services in combination with these interventions used?
Our the our particular client set, we have not had very many participants that are receiving co-occurring PT services. We do have some collaborations with speech and language pathology and occupational therapy. I think the SLPs really bring in that swallow expertise. So if we're seeing difficulties with a child swallowing, maybe they're coughing on thin liquids. We would collaborate then with the SLPs because they are the experts in the physiology of swallowing.
Great. Well, thank you so much. I think that was the last question that we have for you, and we really appreciate you presenting with us tonight.
Of course, thank you so much for having me.
Yeah. Our next speaker tonight is Xing Yi. Xing Yi is an undergraduate at Rice University and worked with Dr. Sarah Elsey at Baylor College of Medicine on her Summer Scholars Project, Remote Assessment of Activity and Sleep in PRISM in Smith-Magenis Syndrome, or REACT. Her work explores how wearable technology can help us better understand sleep and activity patterns in individuals with SMS, an area that's critically important for both research and daily life. Xingyi, thank you so much for being here. We're excited to learn more, and I will turn it over to you now.
Okay, thank you so much. Thank you, Prism, for giving me this opportunity to present. So good evening, everyone. My name is Xing Yi. I'm from Rice University, and I was one of the Prism Summer Scholar last year. I worked with Dr. Sarah Elsey at Baylor College of Medicine. And this was the study we ran last summer. And I'll be sharing some findings we had. Yeah. So before I start talking about my own study, I want to discuss the complex relationship between sleep activity and behavior with individuals with SMS. First, we know that individuals with SMS, they have inverted melatonin secretion, leading to severe sleep disturbance and daytime sleepiness. Second, we often see rapid childhood weight gain that leads to obesity, but their physical activity pattern still remains unclear. And third, there are behavioral challenges, specifically temper tantrums and self-harm behaviors. We know these three factors heavily influence one another, but we haven't quite figured out how they interact. So we asked the question, how do we study these complex relationships in Smith-Magenis syndrome? Current research method pose many challenges to the SMS population. First, a lot of data we have now heavily rely on caregiver reports, which require a lot of effort and can be hard to capture everything accurately. So because of this, we wanted to find an objective way to capture sleep and activity data. Secondly, clinical sleep studies in lab are extremely difficult for individuals with SMS because of the unfamiliar environment can be triggering, and lab doesn't accurately reflect their daily sleep. So we want to find a way to collect data that supports continuous and real-world monitoring. Lastly, traditional in-person research often disrupts routines and requires parents to take time off work and can be costly. So to overcome these barriers, remote studies can really reduce geographic and socioeconomic barriers and research participation. That's why last summer, we ran a pilot study aiming to test the feasibility of remote data collection using Fitbit devices in 11 to 19-year-olds with SMS and to better understand their sleep, activity, and behavior patterns. Specifically, we started by collecting Fitbit data as well as collecting caregivers and participants' daily diaries. Once we have the data, we compare the caregiver reports with Fitbit recorded data. And lastly, we evaluated the granularity of Fitbit sleep and activity data. So our pilot study, we asked the participant to wear a Fitbit for continuously for 14 days. This study was ran through last summer from July to August. The study was done entirely remote, but participants were limited to the US and Canada to control for seasonal variations, and we also restricted to English speakers for easier communication and device shipping since this was only a small scale pilot study. For the device, we selected the Fitbit Inspire 3 because of its slim shape, its good functionality, and overall affordability. The families participating, they completed several surveys, starting from the interest form, pre-study surveys, including child sleep habit questionnaire, body type questionnaire, medication and supplements. They also filled out daily diaries during the study and finished up with a post-study questionnaire. So our participants were recruited through the SMS patient registry. Out of the 34 families that was in the age group, 10 were enrolled. 10 completed the interest form and were enrolled. Eventually, 8 completed the study and were analyzed. So here's the demographic data for our 8 participants that completed the study. Their ages range from 12 to 19. And we had 5 females and 3 males. In the middle, you can see their weight and height data, as well as BMI and BMI percentile. BMI or body mass index is a height to weight ratio used to describe a person's weight status. So for this presentation, we've color coded our participants by BMI category into the colors you see here. So purple is severe obese, red is obese, yellow is overweight, and green is healthy weight. Lastly, on the bottom row, you can see we have 3 participants with RAI1 variant indicated in blue triangles, and we had 5 participants with deletion indicated in red X's. Okay. Here's a visual look at exactly where a participant fall in terms of their BMI. So I want to emphasize these charts are the extended BMI growth chart for males and females. So the shaded regions are where it represents obese and severely obese. The x-axis are the ages from 2 to 20, and the y-axis are their BMI. So you can see most of our participants fall under the obese and severe obese categories. Okay. We took their BMI data and compared with some Fitbit data we collected. We found no clear correlation between BMI or genetic classifications with steps per day. On the graph on the left, you can see the vertical error bars shows very high day-to-day variability within each individual depending on their routine that day. Okay, similarly, the graph on the right, we found no clear correlation between a participant's BMI with their resting heart rate. Next, I'm gonna talk about sleep. So here's an example with sampled numbers showing how we visualize the Fitbit data we collected. So Fitbit basically records if a person is either asleep or awake. We color coded each sleep or awake into different colors. So light blue shows awake, dark blue shows asleep. Orange shows any awakenings in the middle of the night, and green is any naps taken during the day. So in our graphs, we will have time running on the x-axis from 5 p.m. to 5 p.m. the next day, so that the core sleep is in the middle of the chart. And each horizontal bar, each row represents a single day. So this is an arbitrary chart. And next here, we have the actual recorded sleep data for all 8 participants. The background color of each chart represent their BMI category from healthy weight to severe obese. And we also have their genetic classification in each corner, either deletion or a variant. So these bars, the color themselves are exactly like the example we just saw, with light blue being awake, dark blue being asleep, orange being any awakenings during the night, and green being daytime naps. I'm going to pause here for a second because I know this is a lot of visual information to take in at once, but you can immediately see how different sleep looks like from person to person and even from night to night for the same person. But we will zoom in to look at a few specific participants next. So first, I want to start looking at these two participants. They are very similar in terms of they're both 12 years old females with genetic deletion, and they're both healthy weight. On the left, participant 26, she takes no daily medications. You can see clearly that there are a lot of orange blocks showing that she has average about 2.5 hours of nighttime awakening on half of the nights. Compared to the right side, participant 40, she takes a medication listed below here. Her chart showed a much more stable and consolidated sleep. So medication has use on reducing night awakenings, as we see here. And next, we have participant 97, who also had an interesting pattern. He takes medication listed here daily, but according to a caregiver report, he skips Adderall and acebutolol on the weekends. As you can see from the green bars on the chart, he only naps on those specific weekend days, as caregiver reported, suggesting that medications may be an effective way in reducing daytime naps. Okay. Next, here's an example when comparing a caregiver's daily diary to Fitbit recorded data. The reported bedtimes generally agree, as you can see on the left. However, caregivers tend to report later wake times than the device recordings. And more notably, caregivers were often unaware of any middle of the night awakenings. Okay, finally, on sleep, the Fitbit breaks down sleep into 4 stages. We categorize it here: REM sleep in blue, deep sleep in purple, light sleep in gray, and long awakenings in orange. So at the top, we have the recommended sleep hours for this specific age group. Compared to that recommendation, overall, our participants had shorter duration for each sleep stages. However, I want to note that this is Fitbit defined REM sleep, just based on heart rate and movement. So we will need to do more work to fully understand the REM sleep in SMS population. But nonetheless, this is the sleep stage distribution by Fitbit. Okay, moving on, I'd like to talk about physical activity and behavioral data we collected. So in this graph, we asked the caregivers to log their child's daily activity as light, moderate, or vigorous levels. The striped bars here are the average activity minutes of each level based on those caregiver reports. Now, comparing to the solid bars, which are Fitbit recorded data, when we compared the two, we found that caregivers typically underreport duration, but overreport activity intensity. So Fitbit picked up more significantly more light activities, all day movement than a caregiver could track. We saw no clear patterns or correlation between BMI, age, or genetic classification. So overall, our participant had more light activity than we expected from reading from the caregiver report. Yeah. Okay. Next, here is a 14 days of continuous heart rate data for one specific participant. She's a participant that are not on any medications. Her resting heart rate is here, the black line of 57. When we match her heart rate spikes with caregiver diaries, we found that these massive spikes not only align directly to physical activity, but also tantrum episodes. So zooming on to one specific day, this is a 24 hours of continuous heart rate data we collected. The green brackets here shows three light walking sessions reported by the caregiver that day, where her heart rate stayed between 70 to 100. But in the afternoon, there were two heart rate spikes. The first one spiked to 147, and the second one was around 116. This showed that her heart rate during tantrum is significantly higher than actual physical activity. Okay. Last, we collected post-study feedback. On post-study questionnaire, we asked caregiver to rate Fitbit tolerability and turned out to be 8.6 out of 10. And they also rated the fun of the study 7.4 out of 10. Next, we asked if their child completed the daily diaries on their own. Only 2 out of 8 said yes, and both participants had RAI1 variants. The rest of the participants either skipped the form or needed caregiver help to complete it. So looking ahead, we also asked if an activity goal setting with rewards might be a good motivator for physical activity. 7 out of 8 caregivers said yes. So moving forward, we plan to compare our data with matched age and sex groups from the general population, as well as other neurodevelopmental disorders such as Prader-Willi and Down syndrome, who have more wearable collected data available out there. And for future remote studies, our goal is to gather more SMS participants across a broader age range to get more data. And we also like to compare with their neurotypical siblings or add a nutritional assessment. Eventually, we hope to launch an intervention study using Fitbit goal setting to motivate more physical activity. Okay, to finish off this presentation, I'd like to acknowledge the PRISM Summer Scholar Program and the SMS Patient Registry for making this project possible. And I'd like to special thanks to my mentors, Dr. Elsie and Teresa. And most importantly, thank you for the participating families for their time and effort. Before we wrap up, I'd like to ask the parents on this webinar if you could please fill out a quick survey assessing your interest in participating in future remote studies as we expand on this. Please feel free to scan the QR code right now or take a picture of it. And yeah, that concludes my presentation. Thank you, everyone, and I'll be happy to take any questions right now.
Thank you so much. Excuse me. Okay, let's see. I think I've got myself off mute now. Thank you so much for that presentation. That was really interesting and very innovative approach to studying sleep and activity in SMS. We really appreciate the work that you're doing in this space. I do have a few questions for you. Let me take a look here. So the first question is, did the Fitbit collect blood pressure data specifically during increased heart rate due to behavior tantrum?
Okay, good question. So for us, we can look at their Fitbit data through a third-party system called Fitabase. Um, so on Fitabase, we cannot see blood pressure, not for the model that we're using, the Fitbit 3. The only data we can see is heart rate, sleep, steps, intensity minutes, and calories. So no, we cannot see blood pressure.
Okay. All right. Next question. Are you interested in the future in studying adults with SMS?
Yes. So as mentioned, this was only a pilot study we ran during the summer, so we limited it to a smaller age range, but we're definitely interested in expanding. I believe any individuals the age above 10 is the age group we're going for. So yes.
Great. Great. Okay, let's see. Do you know when you will launch the next study and how can families support these next round of studies?
Hmm. I'm not 100% sure about the timeline. That's something I'll have to discuss more with Dr. Elsie in the lab. But I believe when we're gonna recruit participants, not only through SMS patient registry, I believe Dr. Elsie would also like to use the help of Prism to spread the words so we can be more inclusive and have participants, more participants. Yeah.
More. Yes, that would be great. Okay, thank you. Let's see. Next question is, did you look for potential causes for the difference in Fitbit versus caregiver activity duration? Things like stimming or other behaviors that caregivers might not label as activity.
I think that's a good question. So that is certainly one of the challenges we face when analyzing the data because so for the caregiver report, the physical activity section, we asked for them to rank either it's light, moderate, or vigorous activity. We did give them examples of what falls under each category, but I believe like every person have different skills or like different criterias of what they think is what counts as light, what counts as moderate, what counts as vigorous. So that's definitely one of the challenges, which is why it's good with the Fitbit. It has actual heart rate data. It'll be more objective. But the caregiver report, all we can do is use what we have and compare it to the Fitbit data, yeah.
Yeah. Awesome. Okay, I think that are all the questions that we have for you today. I really appreciate your presentation. That was really interesting. And I'm looking forward to more research coming out from you on that. All right, so thank you everyone who has joined us this evening. We are really happy that you're here. And if you'd like to continue learning, be sure to subscribe to our YouTube channel and follow Prisms on social media. Also, consider becoming a member of Prisms if you're not already a member. Membership is free and it's a great way to stay connected and informed. Prisms is a nonprofit organization, and programs like our Summer Scholars Program and the Patient Registry are made possible through the generosity of our donors. If you'd like to support this work, you can scan the QR code on your screen or visit our donation page on our website. So thank you all for being a part of our community and have a wonderful evening.